All right, it's 7 o'clock. Welcome everybody to our webinar. Dr. Martinez, thank you so much for joining us today.
So happy to be here. Thank you so much for the invitation, Raylene. Raylene, you are a personal friend, and I am a huge fan.
Aw, thanks. Well, we are also a huge fan of you, and we know your time is very valuable. And we are honored to have you here talking with us today. And I am recording this webinar as well, so that for our friends who couldn't meet us today, they'll be able to listen to all your fantastic information when they can. So thank you.
And yes, a shout out to Stephanie and Kelly who have logged in. Thank you so much for joining us. We are so happy that you're here.
Last thing I'll say is that I do have the chat open. So if anybody has questions, I'll keep an eye on that as well.
Sounds good. All right. So I made a little PowerPoint presentation for us to kind of guide us during our conversation. Excuse me for noise in the background. It is my son who I am telling to turn down his phone until his dad gets home because I'm sitting. You want to go to the theater room? Go to the theater room. Okay. Well, no noise. Sorry about that. I have two children. One is 10, one is 5. And so I really love taking care of children, and that passion comes out when I'm involved with taking care of patients, especially pediatric patients, but for my adults too. I just really am truly a fan of helping people. So I entitled what we're chatting about today is Pediatric Neurointerventional Radiology. Sometimes it's referred as interventional neuroradiology. But I wanted to kind of make a focus that we're not just veins, brain, spine, head and neck, or arteries, veins, brain, spine, head and neck, but we're really experts who are super subspecialized, and we have a lot of insight to help patients achieve brain health. Okay, so one of the things that Raylene is allowing me to share, which I'm super excited about, is my, did I lose it? No. Can you see my screen still? Is my practice. Clarity, Brain, and Spine. Clarity, Brain, and Spine is the future, I believe. The idea is to provide super subspecialized care and increase access to subspecialists, which can be hard to reach and get to when you're in an academic situation, believe it or not, where I've been in academia for the last almost 8 years. And the goal is to actually allow patients and families and parents and guardians or adults reach out to an expert when they're having complex brain problems or have brain, head, neck, spine questions. And so I chose the name Clarity, and I'm actually going to read the definition. Clarity means clear, to be easily understood, easily seen or heard, and it's a full detail mental grasp of something. And so I chose the word clarity because that's what I want my patients to have after they experience a time with me. Clarity and understanding what their diagnosis is, clarity and understanding how the medical system works, clarity on how to be strategic to optimize care for their family member, for themselves. And also, the part that I really like is making sure patients, families, children, they feel seen, they feel heard, because that's what's going to happen when you come to my practice. So, if you ever had a medical doctor who was an expert in your family, you may know how awesome and useful that can be whenever a medical problem arises. But the goal of my practice is to actually give that access to all patients. And yes, I am going to treat you and your loved ones, your family, like family. So that's just a little bit about my practice.
So we have just one question on that, which is how does it work with you? Because there have been a lot of people who've wanted to do second opinions and things like that.
Oh, you went on silence. You went on silence. Come back, Raylene. It muted
All
you.
right, which might not be in Texas, which is where you're located. So can you explain how you do second opinions and if that's an option for people who are not in the same state as you?
Absolutely. That's a good question. So currently, I am a consultation cash pay only entity. And that, just to make a long story short, it takes time for physicians who have been in academia when they go into independent practice to be recognized by insurance. So basically, the insurance payers, Blue Cross Blue Shield, Aetna, Cigna, they don't know who I am as a physician outside of what I did with other universities. And so I'm applying for that. And that helped me to understand that if you are interested in a consultation, you can form a client expert consultant relationship, pay a fee. I can request your medical imaging, upload your medical records, and review all of those things and discuss with you via telehealth, no matter what country or city or state that you're in, and give you the advice that you need for your next steps. Now, there are limitations though, and this is why I am undergoing the process to get insurance. I cannot write you a prescription with that consult. I cannot book you for a procedure if you needed one. I am not forming a patient physician relationship. It is called a client consultant relationship. And so I can give you all my knowledge, all the advice, look at all your records and imaging. I just can't do things that the doctors can do. However, there are loopholes around that. And that's just basically if you and your pediatrician or your neurosurgeon or neurologist or any other healthcare provider sent you to me, we could work together and they could utilize my expertise to help you implement your plan at home. And I also give advice for physicians I trust, places that you can go to kind of get that process started. And that's until I actually have access to book you as a patient. So, long story. Sorry I couldn't make it shorter.
That's okay. One other quick question before we get started is can you tell us a little bit about your history and expertise and what you do for everyone?
Ah, yes, yes, that's a really good question, really. So, I am a radiologist by training, and a lot of people are familiar that neurointervention, there's three flavors, meaning there's three pathways that you can become a neurointerventional radiologist. There's the radiology pathway, which was the first, because you're using image-guided procedures to perform interventions and fix things and makes things better. But you're also using that imaging to diagnose patients. And as a radiologist, I trained on how to read CAT scans, MRIs, ultrasounds, all the imaging modality, PET scans, even if you had a stress test. I was trained during medical school to read that imaging. So I'm not only able to interpret these studies that are being performed by different physicians, I can utilize those studies to make diagnoses as well as create a treatment plan. The other two people who do neurointervention are from a neurosurgery background and a neurology background. Now we all have our strengths, and I would say we all have our weaknesses, but I don't 100% believe in that. But well, everyone has a weakness, but neurosurgeons, they can actually cut and open the brain to do procedures, as well as travel inside the vessels to do procedures. And neurologists can travel inside the vessels to do procedures, and they are very good at diagnosing because they're considered the clinical neurodiagnosers. And so, as a neurointerventional radiologist, there are many specialties that I cross over with as a specialist, even though I focus on head, neck, brain, and spine. When you're talking about vascular malformations or birthmarks, that is something you would see me for if it involves your head, neck, brain, or spine. If you're talking about, I have chronic back pain, or I have this pain in my back, and can you look at my imaging and help the orthopedic surgeon or neurosurgeon help me figure out what's going on with me? I can have that conversation. If you just had a brand new baby who was diagnosed with something that maybe inside their head doesn't look quite right, as a neuroradiologist and a pediatric neuroradiologist slash radiologist, I can review that imaging and help things that may be subtle be found. So I'm a diagnostician because I understand all imaging, but I also do procedures, minimally invasive, with the use of imaging in order to correct things like if you're having a stroke or you have an aneurysm that ruptured and needs to be fixed, or you have an aneurysm that is incidentally found and needs to be followed, or you're having chronic headaches and no one can figure out why your headaches are still happening and migraine is being said, but your medications are not working. I would like to say I'm the secret sauce for complexity. And when the physicians cannot figure it out, but it's even more than that. So I hope I answered your question, Raylene. There's a lot of things that neurointerventionalists can do. But yeah, that's a little bit about.
Is an example that people would know here like angiograms? Would you be part of an angiogram procedure?
Yeah. So whenever you're dealing with getting more information, so most times patients are going to undergo CAT scan, maybe ultrasound for children, or an MRI. And if something is diagnosed on that needs more investigation, then you may get an angiogram. And that is one of the procedures that we perform using x-rays machines to go inside the vessels and actually get information about what those vessels look like and how blood flows through the circulatory system and making sure that it's functionally doing what it's supposed to do. And if it's not, these are things we can actually identify by using an angiogram that maybe we can't get all that information or only part of the information with non-invasive imaging such as MRI, CAT scan, ultrasound. So yes, I do those, but also pain injections if you're having chronic back pain, diagnosing why. I also do, let's see, like I said, the headache thing. So if you're leaking cerebral spinal fluid, I can patch you up to make you not leak it. Or if you're having increased production of fluid and headaches that are due to that reason, I can help diagnose you why that's happening and possibly open up a vein that's causing that to happen. So there's a lot of things, and I encourage everyone to just, if you have a problem, reach out.
All right, well, let us know about this case study.
Okay, let's go on. Can you still see my screen?
Yep, we got you.
Okay. Well, we'll come back to this question. All right. So let's all put on our medical hats. And this is something that's very dear and near to my heart because it's cutting edge, breaking new research and discovery. And it's something that has been underdiagnosed, misdiagnosed for many years now. It's actually becoming a disorder that's being found to be very common. And I'm going to go about explaining concepts to you by sharing an actual story of one of my patients who has agreed to tell her story. We're publishing this case report right now. But this story begins with a 16-year-old girl who presented to my hospital for an angiogram because she had been diagnosed with a possible aneurysm, and this is actually her CT angiogram. And if we look right here, and I hope you can see my arrow, it looks like there's a little nubbing on the vessel. So this had been read at an outside hospital of being a problem for her, a possible aneurysm for her. And the family were just consulting with me because they wanted to make sure their blood vessels were okay, her blood vessels to her brain were okay. And so, yes, I'm an expert in blood vessels that take flow to the brain or away from the brain. But when I reviewed her study, I didn't think this was an aneurysm, and it was not. And I listened to her tell us what led her to get the CT angiogram. So the story goes like this. This patient was totally normal. She had a history of congenital scoliosis. But while she was on top of the pyramid cheerleading, she experienced a sudden pop in her back. Okay. So she was a cheerleader. Her congenital scoliosis was not slowing her down. She was very active. But one day she was thrown up to the top of the pyramid and she had sudden pop in her back and then sudden onset of pain. She goes to her local ED and everything that she had experienced had normalized by then. So they sent her home. Neurological exam was fine. No imaging was done. They just kind of chalked it up to, oh, you must have popped the muscle or moved the wrong way. Now you're doing fine. You're feeling better. Go home. Now, when she had the pop in her back, not only did she experience severe back pain suddenly, but she also noted that she couldn't move her arms and she couldn't move her legs. And so by the time, like I said, when she got to the ER, all those symptoms had resolved and they couldn't find anything wrong with her. She went back, started cheerleading again, and again, this time she felt a pop in her neck. Instead of rushing to the emergency room like they did the first time, they decided to kind of like let her stay home and kind of keep an eye on things. But things got worse. She started having those episodes where she couldn't move her arms or her legs. She kind of felt paresthesias, which kind of feels like an abnormal nerve sensation. Maybe if you ever had your arm fall asleep or hit your ulnar nerve, which some people are like, you hit your funny bone, you get that funny feeling in your arm. She was having that, and it was episodes that were on and off over the last 3 days, and then things would go back to normal. She also started having episodes where she would lose consciousness for 10 to 15 seconds. She would kind of warn her mom that she felt like she was about to pass out, and then she would just kind of slump over and not be able to be woken up for about 10 to 15 seconds. Now, this time, because this kept happening and it kept becoming more frequent, they took her back to the emergency room. She had a normal neurological exam. They decided that the episodes were not seizures because she didn't have incontinence, meaning peeing on yourself during the episodes. But she also reported to them that she was having this 8 out of 10 headache pain. They did a whole bunch of imaging, including the CT angiogram, and it was considered to be negative. She was transferred to our hospital at the time, my old hospital, and ended up 3 nights in the hospital. No one can figure out what was going on. So now she's back home. She's here for this angiogram. Her parents are like, we're doing everything they told us to do. Her medical history revealed that she had a history of anxiety. So they said, you know what? Since all the testing is negative, we're going to chalk this up to a psychiatric problem, do some cognitive behavioral therapy, and you should get better. You're a 16-year-old, you're stressed out from high school, you're about to be I think she was a junior, so you're preparing for your senior year, and this is probably just stress, and you already have the history and the anxiety. So when they present to me, they're truly both parents, mom and dad, were in distress. And they say, you know, we're doing everything they told us to. She's doing the cognitive behavioral therapy. Things are not getting better. Sorry. She's truly not getting better. And we don't know what to do anymore. It's unsafe. She has her driver's permit and we're afraid she'll lose consciousness. She's losing consciousness for longer. Okay, so long story short, I looked at her and I said, I think I know what's going on. And I changed the order for her an appointment and I asked her parents to trust me. And I said, instead of doing an angiogram, let's do a test called a myelogram. And what I suspected was that the fluid that's around the brain that makes the brain happy and healthy and also makes the nerve tissue happy and healthy had came to a point where it was not balanced. And so the myelogram is a study where we put contrast into the spine and we check to see if the contrast leaks out. And so what I found was exactly what I suspected. This is a few slices through her myelogram where here we can see the spinal cord. We can see the fluid that I place in, the contrast dye. And basically there's a saran wrap like covering called the dura or thecal sac that keeps all the fluid bathing the spinal cord. This extends around the brain and down the spine. If there is leakage of that contrast outside of the circle, that means the fluid that is responsible for helping the brain function is leaking out and it's not supposed to. So here we can see these arrows are indicating where she was leaking from her thecal sac. And even here, it's even more obvious where we have a jet of fluid where everything is supposed to be inside, staying around the spinal cord. It's seeping outside. So we admitted her to the hospital that night. And the next morning, I performed a blood patch. Blood patch is when you take your own blood, you place it into the space around the thecal sac, and it actually causes healing of the areas where the leakage was from. Immediately, her symptoms got better. She didn't have any loss of consciousness. Her headache, which was 8 out of 10, went to 0 almost less than 24 hours after the procedure was done. However, with time and increasing activity, she started developing her symptoms again. And we would go back through that cycle where I would bring her back, place more blood into that space. She would get better. And then as soon as she got up and active again, she would start having these crazy, strange neurological symptoms. So here is a picture of a MRV. This is MRI looking at the veins. And what I knew, but the family were not so much aware of initially, is that the CSF is responsible to drain through the veins. So if you have an area in the vein that is causing that CSF to not drain back down to the heart through the jugular veins, it can cause an imbalance in the fluid production and cause brain symptoms, headache, leakage of fluid because the balloon around the brain, the thecal sac, the dura, around the spinal cord, it creates holes within it because the fluid is no longer allowed to drain to the heart like it's supposed to. It begins backing up, and then there's transmitted pressure where it can start to leak out. And so here is a venogram. Now, the audience may be very familiar with an angiogram where we're looking at the arteries to the brain. But the point of my talk and the importance of the research that I'm doing, we can't just pay attention to the arteries of the brain. Yes, they're very important, but the veins that drain the brain are just as important. And we're finding out that they're actually probably the cause of many of the issues that we get when patients have vascular malformations and things. So here we could see on her venogram where we have very tight stenosis, where it was keeping her from draining her CSF like she was supposed to into her jugular vein. We placed a stent to open up that tight channel here, and she stopped having all of her symptoms. She never redeveloped a leak. She got better. And she's now in college, going to medical school, and she's going to be an author of the paper about herself to help her get into medical school. And so here's a paper that I commonly reference about leaking and high pressure. High pressure has been thought to be a disease process. Leaking has been thought to be a disease process. But what we're learning is that patients can have high pressure, then blow up that balloon so much with all the pressure, kind of leak like a tire with a hole in it, and then go through that whole process again where the leak is sealed or patched, but now the fluid is overproducing and making too much. And then you get that increased pressure again, and then you leak fluid, and it just causes the craziest symptoms. Most patients are being diagnosed as having psychiatric issues. Patients are saying they're depressed, they're anxious, they have migraines that are headaches that causes all these strange symptoms, but none of the migraine medications work. And it's actually due to this underlying phenomenon of CSF. You're having too much sometimes, you're having too little sometimes, and the brain, which is responsible for how all organs work throughout your body, cannot handle that. So that's some exciting work that I'm doing in regards to brain health and CSF and venous stenoses or obstruction to CSF drainage. Any questions about that exciting stuff? Okay, I get excited. Maybe no one else is.
Oh no, I think it was really, really interesting. But one of the things that, I found the most interesting, which I've always found the most interesting about you, is to me, you're one of the only neurointerventional radiologists, or one of a more limited amount. I'll say it that I've talked to several that are this way, but it's not as prevalent to really pay attention to those veins and making them just as important as the arteries. So for a lot of us that are dealing with lesions in the brain vessel disease,
Yep.
right? Whenever we talk to the doctors, the focus is 100% kind of on the arterial side. But when I look, especially overseas, with like Rene Chapeau is a common, right? Well-known guy, right? In Germany, he
Yep.
focuses a lot more on the venous side. Can
Yes.
you, and I think I know the answer, but I would much rather hear it from you, because that is not looked on as a way of treatment very much in the United States. And I think it's due to perceived risk. But please, I'll let you go
Yeah.
on from there, because I think it's really important for families to know about this.
Absolutely. So we're finding that we've been focused on the artery the whole time, thinking it was the reason why pathology happened. But because the veins are responsible for draining the vein, we are honestly thinking a lot of these vascular disorders occur because the venous system is not functioning like it's supposed to. And so even as we're trying to figure out why do some patients develop AVMs, why do some patients develop AV fistulas, there's a very, very high correlation to what are the veins doing and how does this vein relate to the problem. So I'll give you an example. When it comes to AVM rupture, 9 times out of 10, the reason why a patient has a rupture is because the veins are overwhelmed. It's not the artery that causes the problem. It's very uncommon to find what we call a feeding artery, the artery to the AVM, or the nidus of the AVM to have an aneurysm on it, is actually the veins that are under so much pressure, they rupture and that causes bleeding. We're also finding that patients become very symptomatic from these shunts, AV shunts, artery to venous shunts, because the venous system gets mucked up. So, a patient may have an AVM or some type of vascular problem in early childhood, but they only become symptomatic over time because the veins wear out or the veins stenose down. And then the patient all of a sudden now has no way to get, for the lack of a better word, the garbage out of their brain because the veins are responsible for helping get rid of the CSF and some of the what we're discovering the lymphatic system's functioning, which is responsible for cleaning the brain. People have heard about the lymphatic system and how it works best when you go to sleep, et cetera, et cetera. There's a close association with its function and the venous system. So when you start mucking up the veins, this causes the patient to have seizures. This causes the patient to become very symptomatic. And we are wondering, is it thrombosis or changes in these veins and development of these veins that leads to these abnormal connections happening, such as in vena-Galen malformation or dural sinus malformation? It seems to start off to be a venous problem, and then the arteries are responding to the venous problem. So if you go to Europe, like you're saying, there's a lot of colleagues of mine over there, and it's starting to grow here in the USA, where we're really focused on veins being the future of brain health and diagnoses and making sure patients are doing better. So,
Have you seen venous fistulas, I guess, um, become an issue after AVM removal, like the veins changing? We've had a couple of that with some of our community members recently, and it's really not something I'd heard of before. But when you were talking about that, it made me think of that whether, because usually they say, okay, well, AVM is somatic. If it's a somatic mutation, it's a KRAS mutation, right? And so if you can get all of this cell, it's gone, it's gone. But if it's but so I'm a little confused on why we're now seeing, at least with some people, these, I think it's called, like, is it a fistula that are
Yeah.
forming?
Yeah. So when veins clot off, one of the things that they do in order to reopen is attract arterial inflow. So when we talk about dural AV fistulas of the brain and the spine, which do not normally occur in young patients, but it's thought to be brought on by thrombosis, meaning clotting of the vein. And then in order to recanalize, reopen, it somehow sends some signals and messages, probably through those pathways we're going to talk about when it comes to those medications, to cause an abnormal connection between the artery and the vein. This is what happens in vena Galen malformation. This is what happens in dural sinus malformation, where we think that there's an abnormal vein. In vena Galen, it's a vein that's not supposed to be there that stays there. And now it has these abnormal arterial networks feeding into it. And you get such shunting that the baby, when it's born, they have heart failure and issues. And then with dural sinus malformations, this was a paper that actually just I published with my group the day yesterday. Yesterday, we told the story of a little baby who develop abnormal veins. They ballooned. When veins balloon, they actually don't have good blood flow through them. And because they're such a low pressure system, when you don't have blood flow going through them, blood flow clots. Like if blood is not moving, its natural predisposition is to just clot. And so this baby developed this dural sinus malformation and it clotted off. It gave the craziest presentation at birth, including seizures. But sometimes those babies also suffer from that abnormal connection of the artery to the vein. So we wonder with these patterns, and that's all we have to kind of figure out what's going on. Is the whole AVM triggered by some abnormal venous pathology that sets up for this artery to venous connection? That's where the research is being done, and that's what we're pursuing to learn more about. But yes, with an AV shunt, it wears out the veins. It causes the veins to narrow down, and with narrowing, again, you're dealing with decreased outflow. And with decreased outflow of blood, you can get clotting. And with clotting of veins to the brain, we already hypothesized that's why older people develop dural AV fistulas. But then there's whole other factors with MEC and KRAS and all those things that are interplaying for children. And it's exciting, interesting stuff. Actually, AV shunts are my favorite pathology, if doctors are allowed to say that out loud. Meaning it's truly understanding brain mechanisms, embryology, development, molecular biology to really put the picture together to come up with why it happens so then you can fix it when it happens. So, yeah. Fascinating stuff, Raylene. Raylene, that's why I say you're a genius.
No,
Like
no. I have one other question
partners.
though on that.
Yes,
And then
yes.
I know we'll move on because I really want to move on, but
Go for it.
I
Go for
can't,
it.
help myself since we're all into the vein now. So I think I understand that if that's why, like, older people, or what you were explaining, people who have had these malformations could be then later having these fistulas. It's the same thing. That's why if you've had an AVM in the past, it's something to look at or consider if you're having symptoms in the future, even if you're considered brain vessel disease free for whatever time, right? Did I understand that correctly?
Yes,
Okay.
yes.
So
The
then my
veins
next,
are going to take the hit from having too much blood flow through them because you had the shunting in the first place.
right, because
Vein
you had
keeps
so
clotting.
much amount of time where it was like too big, right?
Too much flow through it.
Too much flow through it. Okay. So here's my other question. Um, what's super frustrating for us sometimes is when we're told, I can't do treatment, right? We can't remove it. And we're going to get into that with the medications too. So I'm kind of leading on with that question. But my question is, I understand that for embolization, for example, you have to be very careful because what is an ischemic stroke? An ischemic stroke is when there is a clot, right? And the clot is in the brain. And so now we've cut off tissue where it's important, and that's a no-no, right? And so a lot of times on the arterial side, you can't treat it by doing a embolization. And one of those reasons is because you would then cause essentially an ischemic stroke if you did and kill healthy brain tissue, right? So my question is, for people, especially for us who've been said, no, we can't do that. Why can't you do it on the venous side then in some situations, if you can't get to it on the arterial side?
Great question. So our arteries are very easy to understand. Most people have very similar arteries as another person has. So the anatomy is very straightforward, and making the road maps to get where you need to go is a little bit easier. Venous treatment of AVMs is a newer offering being more recently discussed where people are saying, hey, if you can't get there through that pathway, go backwards through the draining pathway. But there are a few limitations. One, if you don't know your anatomy very, very well, you can get into trouble faster and cause more harm than good. So you really want to be an expert in venous anatomy and really know your anatomy. And I'm not saying doctors don't, but I mean, it takes another level of study to understand the venous side, the variations that most patients have on the venous side, because it could be me, you, and a third person in the room. We all have the same arterial pattern, but when we look at our veins, there is no pattern. It is not this vein leads to that vein, drains that vein, drains that vein. So it takes a higher level of understanding. Two, veins can be fragile, okay? They are not made up of the same structure that arteries are. Arteries have a muscular layer that makes them more robust and ability to travel inside and get away with it, for the lack of a better word. Veins, which are thinner and don't necessarily have that muscular layer, especially the veins inside the brain, they are more likely to rupture easily, especially if they've been under pressure and they are ballooned and, are pathologic because of this AV shunt that's been happening. So there are more risk or maybe increased risk when you're saying, I'm going to go the venous way. And if you're uncomfortable with the anatomy and it's a child and this is a newer procedure that we're offering and we're still trying to figure out how to optimize it in adults, this may not be an offering that your neurointerventionalist wants to offer to a child. And then last is sometimes those veins wear out to the point where there's no access to get to them. So as I was saying, when you have increased flow with time, you get something called a venopathy. A venopathy means that that vein kind of wears out and it can balloon up or it can actually stenose down and close off. So now
And that ballooning up is aneurysm? Is that when you most
it
likely
is
see an aneurysm? You said it was not
it's
arterial, it's normally venous, right?
a venous aneurysm is something that we use the term. Some people call it ectasia. We don't like to use the word aneurysm because that can make people very nervous, even though it functions differently than an arterial aneurysm. But yes, ballooning is venous ectasia or aneurysm. These are terms that are synonymous, but sometimes those veins actually close down, and that can cause the internal jugulars, which are going to be your access point to get up into these veins, they wear out and they close off. And so now this little baby that has, or child or teenager who have had an AV shunt, you can't even access where you need to go to get where you need to go because that vein has closed off in response to the ongoing increased flow and damage. So it is, I think, going to become more common and more of an offering, but with all those limitations and the newer discussions, we're not really saying for children, this is the way to go. This is the way we're offering immediately. Because arterial embolization, we've been doing it for years. We know the risks, we know the outcomes. The studies have been done that show good outcomes and to a certain extent. And so vein is like the new uncharted frontier. And when you have uncharted frontiers in children, we're not offering that right off the cusp. Yeah.
No, it makes sense. Thank you so much for explaining it, and I'll let you continue on with, okay, let's say we can't do the treatments that we've been talked about, which is, removal, resection, right, or embolization, and maybe not radiosurgery, stereotactic radiosurgery. What are you seeing new on the front for treating brain vessel disease?
Absolutely. So, very good question. This schematic, I am not even going to go into it because every time I see it at a conference, I kind of get heart palpitations because it's a lot going on. But there are three types of drugs that are being utilized in certain scenarios, not for every scenario, to treat AVMs. And so it goes back to the fact that AVMs, for the very longest time, have been entities that function a lot like tumors. And so I'm actually going to go back to this and not to explain it all, but and basically, we've always said AVMs grow, they take up space, they can harm the brain, they can bleed, and they seem to want to just actually parasitize, meaning pick up other vessels that are around and invite it to the AVM party and continue to grow. And we see this oftentimes in children, where these AVMs can start off small and just continue to grow and grow and grow and grow. So a lot of times they can behave like they're tumors. And I think that association led to we have medications that are responsible for getting rid of cells and tumors. Can we apply some of those medications to an AVM that is not a tumor, but kind of functions like one? It wants to grow, it wants to bring in more vessels, it wants to bleed. And so that led to, and now we'll go to this page, three types of drugs. They're currently being investigated today. None of these are on-label treatments except maybe this KRAS inhibitor and well, not for AVMs, but this KRAS inhibitor. None of these are on-label FDA-approved drugs for AVM, but we are utilizing them in the scenarios that you just said, Raylene. So when it comes to a patient who has an AVM in a part of the brain that is too risky to radiate because then you're going to radiate the structures around it and cause permanent damage and neurological disability to the child, or it's too deep to get into surgically, or if you embolize it, you're going to cause more damage to the surrounding tissue that's normal. We are starting to look at these drugs to offer to patients. We're also looking at patients who have um, AVMs that really function like tumors. And what do I mean by that? They're aggressive, they keep bleeding, they seem to keep growing, they're changing. You get an MRI one year, you get an MRI the following year, and things have changed. Things are not quiet. The child is very symptomatic and they're having problems that keeps them from being able to be a child. So we're offering this to patients, these medications. Then you have the child who undergoes a biopsy or sampling, liquid biopsy of the cells from the AVM, and you find out that some of these receptors are actually on the cells of the AVM, and some of these medications can address those receptors. And then you have just clinical trials. And I put this website here because this is actually the page that gives you all the clinical trials that are going on in the USA. If you wanted to investigate for a family member who is in need of a miracle in medicine, this page will show you all the studies that are going on. But clinical trials is also one of the places where we're using these medications. Lastly, patients who are born with syndromes, capillary malformation, capillary malformation AVN syndrome is one of those entities where it's a genetic mutation. It predisposes a child to develop AVMs, develop hemorrhage at a very early age and throughout their life, but also gives them other issues and symptoms. So these are the conditions where we're saying, hey, we need to do something to help this child. There's nothing else we can do, or it's very aggressive, or they have the genetic support that these medications may work. Let's give a medication that they can take. So, CRAS is one of those genes that can be found on an AVM. You have to specifically find it on an AVM, and it can be targeted by the drug that is a CRAS inhibitor. And you sent me the name of it, and I'm gonna just cheat and look it up because
Starts
person,
with a T.
well, this one is actually the one that starts with a S.
Oh,
It's the only one in its kind. Sotorasib. Sotorasib is a KRAS inhibitor, and the only way you can qualify this drugs is if your AVM actually has the receptors that KRAS can bind to and inhibit. So it's rare that you will undergo a biopsy or be identified as a patient who has that receptor on this AVM, but it's administered. And the idea is I'm giving you these medications to quiet the AVM, keep it from growing, and stabilize it. But only animal studies and a few case reports are in support that this works. And then you have MEK inhibitors. That's your trinatinib.
okay, okay.
And that's here goes your NIBs. Trinatinib, and I'm going to look up the other ones because I just remember them as NIDs. Selumetinib. These are going to be in Cabometinib. They all end in NIB, and they are MEK inhibitors. MEK inhibitors are downstream from KRAS, so a little bit more focused on um, blocking here, the AVM. And so these are actually becoming more and more um, recognized as a possible treatment. Um,
So
and
is it blocking part of the gene or
it's blocking the proteins that the genes make.
okay.
Okay. So you're blocking production of proteins that would help the AVM, in theory, continue to grow and be a problem and leak and ooze and keep other vessels from joining it, etc. In theory, it's going to cause shrinkage and now allow it to grow, make it quiet, and possibly even shrink it. Now, the last drug that we're going to discuss is Avastin. Bevacizumab. I like to say Avastin because this one's a beast. And Avastin is not in this chain of products inside the cell as proteins that are being made, but it actually is a blocker, as you can see it here, for VEGF. VEGF is something that AVMs produce overwhelmingly when they're present. And so, what they've seen with treatments of AVMs, when you're having like radiation therapy, and then you get a whole bunch of edema and leakage, and cells around it are in distress, by giving Avastin, you kind of quiet the AVM from secreting the factors that makes it want to continue to grow, to kind of salvage and kind of calm down what the AVM can probably do to the environment around it that it's in, if that makes sense. And so it's not thought to be necessarily a AVM shrinker, but it's more so calming down what AVMs produce, which is VEGF, which is thought to cause the AVM to function in a way that's not helpful to a patient. And so why isn't everyone getting these medications? Well, again, if you don't fit the criteria we discussed before, there's a treatment for you like embolization or radiosurgery. You're very asymptomatic, you're not having problems with it. It's not taking up a whole cerebral hemisphere of your brain. You're not bleeding every year. You don't have the genetic testing. We don't have enough data to start giving this to every patient who has an AVM because we don't know if it will target the genes in protein production like it's supposed to. And we don't know if the side effects in a growing child will be more significant than the benefit of the drugs themselves. So it's very early, and there's just not enough data to really give that to pediatric patients. And again, adults may be more likely to get access to these medications. Children who are growing and are developing are going to have a harder time getting access to these medications because we're not sure 100% what they do and how they impact development.
Are they in, so are these in the trial stage now?
Some of them are. Some of them are being utilized for patients who have syndromes like capillary malformation syndrome because they have been um, um, approved for certain rasopathies or syndromes that patients have that are genetically diagnosed. And so they know you have the genes that these medications can target and slow things down and make things better. So those patients are kind of like frontline getting those medications, and then patients who are not falling into that are getting compassionate um, capability to have access to the medicine, or your um, academic institution may recommend that you pursue a clinical trial.
Makes sense. And I don't know if you know Dr. Martinez, but Kyler had excessive swelling from radiation, such that it caused a midline shift. It was getting really bad. And I believe the Avastin in his case saved his life because it caused the capillaries or whatever that was going insane to calm down,
Okay.
to shrink down.
Exactly.
He
And
had
that,
5 rounds of it, and I guarantee you, if it had not been for that, I don't think he would be here today. So, for what I've seen, y'all still sure seem to have good ideas about what might work.
yeah, and that's exactly it. They're believing that with radiosurgery to an AVM. You're breaking down the AVM. The AVM is going to release more VEGF. That's going to cause more edema and toxicity to the surrounding tissues. And that Avastin medication is going to calm that down. Again, it hasn't been shown to necessarily shrink an AVM or make an AVM go away, like the MEK inhibitors, which are the NIBs, trametinib, or the KRAS inhibitor, which is the other one. Um, but yeah, that's where Avastin is shining by exactly response and decreasing edema after radiosurgery.
Is it hard to go in there, or is it very, dangerous? Like, I wonder when people are diagnosed with AVM, why do we not have regular genetic testing? You said it's like there's a fluid thing where you can gather some of the cells.
Yeah.
Why is this not standard procedure?
It is very novel. It is still being investigated, and that's how science works, right? Where we have these great ideas, but we can't just start using them because they can cause a lot of harm to patients. So when it comes to an AVM liquid biopsy, there have been a few iterations of how to do it, meaning one doctor may say, I'm going to put a coil into the AVM and pull the coil back out. And then the cells, I'm going to collect the cells off of that coil, which is a wire, a metal wire that you can place into the brain. Pulling it back out, can that cause rupture of these vessels? Can it cause damage to the patient? Do you get enough information to actually make a diagnosis? These are all things that are being investigated. Another way to do it is to go to the venous side and catch the blood that's coming out of the AVM. And again, that leads to can I get to it? Um, do I get the right vein that gives me the most information to help the patient make the diagnosis? How much risk am I exposing him to? If I go and do it and it comes out inconclusive biopsy, did I put them at too much risk without justifying it? So no, it's not standard of care, and science has to be proven to be safe before you start doing it in humans. And so even getting a lot of numbers of patients with this diagnosis, because it's not so common, you're struggling to get the numbers to show that it's actually a benefit to make it kind of routine. Yeah.
Makes sense. So I know we've got a couple minutes, and so I did want to open it up. I know I've asked a lot of questions, but I do encourage anybody else, if you have questions of any kind for Dr. Martinez, if you want to put them in the chat, we're more than happy to, she's more than happy to answer those for us tonight.
Yeah, Raylene she said it right. She can answer them some too.
I can't, but I can make sure you know what they are and you can answer them. So, yes. Well, is there anything else that you wanted to talk about or that comes
Oh,
to mind? Again, people, if they want to, they can go no matter what state they're in. You have a fantabulous Dropbox link. I can tell you, I have used it for another one of my children, and you just can get the files, upload them to you, set up the appointment, and receive the consultation. And then when other things need to happen, you have a fantastic network of other doctors right now who can order the procedures and basically just make Dr. Martinez part of your team if it's something that you guys are wanting to do.
absolutely. Yeah. Raylene, you hit the nail on the head. That's all I had to say. And my email to start the process is care@Clarity Brain and Spine. My website should be up in October, which is going to be claritybrainandspine.com. And yeah, feel free to reach out because I'm on the other side, just waiting to share all the many years of school that I went to with everyone else.
Well, I do have one question that's popped up that says, Raylene mentions the IPSO. What is the IPSO, Dr. Martinez?
Yes, the IPSO, we call it for short, is the International Pediatric Stroke Organization. It was created by doctors who really wanted to raise awareness around stroke in children. And it's a new nonprofit organization. The physicians who are primarily involved are out of UCSF. And the goal is, again, to raise awareness, advance education, and advance research for children who suffer from stroke. And so, all of the topics that I talked about, even CSF pressure disorders, which doesn't fit exactly into the stroke category, have been topics of discussion that we're trying to make sure that we let clinicians know and other providers know, well, clinicians, about what can happen to children, what can happen with their brains, and how to make them better. We've done a bunch of scientific work together where we're publishing papers on protocols and guidelines. We have a conference that we do each year, well, every other year in person, 1 year in virtually, to just educate and share the latest topics and data. A new part that Raylene and I are working on will be I am going to be the liaison for advocacy, meaning bringing to the attention of the healthcare providers, whether you're a physician, an advanced provider, nurse practitioner, physician assistant, physical therapist, occupational therapist, all comers. What are the parents saying that they want from us healthcare providers? How can we help you better? How can we be a voice to you? And how can we communicate and let you know that we got your back and we're doing everything we can to research things to help children who end up coming up with these unfortunate brain conditions. So that's what the International Pediatric Stroke Organization is. And I think as we continue to evolve, it will only become more and more helpful to families and patients that are in need.
Fantastic. Well, again, I know your time is very valuable. I promised I'd have you out by 8 o'clock, and it's 7:59. So I am keeping my promise, and thanking you so much for your time and visiting with us today.
Thank you, Raylene. Again, I think you're a brilliant woman. I cannot say that enough. I am so happy to talk to you and hear on behalf of the many people that you help, what their struggles are, what their questions are, what their dreams are, what their hopes are. It's truly a pleasure working with you, and thank you so much for the invitation tonight. I hope I didn't bore everyone out there too much.
It was fantastic. It was fascinating, and we hope that you'll come and talk to us again. And good luck with your business and also your continued research to help the kiddos that we really appreciate that so very much.
Thank you. Thank you so much.
Right.
Bye. Bye.